Well, howdy New York City. It's Tony Hunter here, and I'm delighted to see so many of you have joined this webinar already that we're delighted to be hosting with colleagues from the British Red Cross on the complex and important topic of reablement. Yeah, I'm Tony Hunt. I'm the Chief Executive here at the Social Care Institute of Excellence. I'm a social worker by background, and I'm going to ask my colleagues from the British Red Cross to introduce themselves.
Hi, I'm Alison Kay. I'm the UK Head of Development for Independent Living.
I'm Helen Sipthorpe. I'm Operations Manager for Independent Living Services.
Hi everyone, I'm Colin Brown, the UK Director for Independent Living and Crisis Response.
Okay, so I don't know how many of you have been part of a webinar before. This is about my third. It's a kind of a strange disembodied experience, but pretty stimulating as well. So as well as the presentation materials which colleagues from the British Red Cross are going to give, and of which we'll send out to yourselves afterwards, by the way, anyway, that'll in turn stimulate all sorts of debate and questions. So we'll be looking at what's coming up on the screen from yourselves, and I'm sure we're in for a pretty invigorating hour. Okay, so reablement. Yeah, and I had a very quick look actually on Google just before, not that I don't know anything about it, of course, just before we started, and you know, very much the way of redeveloping skills to live the lives people actually want. But you know, we've been working in one county very recently where it's become a much more of a broader issue in the sense, is reablement a service? Or is it an approach linked with independence, which really is what good, you know, social care and support, cross-health social care really ought to be about. So some fascinating territory there. But I'm going to hand over now. Oh, Steve, any housekeeping stuff? That is my the man at CNA. Here he is, Steve Palmer.
Yeah, only say if you're listening in and you start a chat amongst yourselves, please do. But remember, if you're using your personal information like an email address, then the whole world can see it. So just bear that in mind if you chat amongst yourselves. But please do chat amongst yourselves if you're thinking of sort of doing some learning from this event.
As you can see, Steve was well rehearsed for that little bit of input there. Okay, so now I'm going to hand straight over to Alison, who's going to start talking about some of what the Red Cross believe and experience about reablement.
Okay, thank you, Tony. So at the British Red Cross we work obviously independently, but quite a lot with the broader voluntary and community sector, and reablement is one model of support that we provide. We work between home and hospital, and we provide reablement support predominantly in people's homes. Helen, my colleague, is going to talk about that in practice. But we have commissioned both health and social care services, so we work in both health and social care and across in an integrated way as well. We are obviously focused very much on maximising people's independence through the support that we offer and developing people's confidence. We work towards agreed outcomes with individuals that we support within a fixed time frame, usually between 6 and 12 weeks of support, and slightly longer if people require that. We do provide a range of activities, practical and emotional support to support and promote independence, and we're very focused on what people can do for themselves rather than what they can't, and we use an outcomes focused approach. Okay, sorry, I'm a bit quiet, sorry, I'll speak up. Which we call What Matters to Me. So we use that as a goal setting approach, which again Helen will talk about in more detail. Do you want to go on to the next slide? We are very focused on supporting the ambitions of the long-term plan. Our services also support the reduction of pressure on A&E services by providing people with supported discharge, and once we're home. Sorry, I'm being told to speak loudly, so I'll try that. Once people are home, obviously supporting them around reablement. We obviously aim to support and boost out of hospital care by providing that support in communities. And again, as I referenced earlier, you know, it's very much focused on the individual individual needs. So it's all very much needs-led and targeted at people who have the greatest need. We're very focused on giving people choice and control over the services that we offer in terms of providing personalised care, and we ask people, as I say, what matters to them in terms of their individual strengths and needs. We do work very much in partnership with other organisations, and as I say, we're very focused on the role of the voluntary and community sector in supporting health and social care to reduce health inequalities too. So I will hand over to my colleague Helen. Oh, sorry, no.
You've got one more to go, Alison.
Sorry, I've got one more slide. Sorry, I've got one more slide. Sorry. In terms of the support that we provide, we've been working within health and social care for over 30 years. We've worked with the NHS and social care for a very long time. Our offer is UK-wide. We work in around over 100 hospitals nationally, including 20 A&E departments. In terms of the outcomes that we are aiming to achieve, some of those are obviously for the individual, as I referenced before, so individual outcomes focused, outcomes for individuals, sorry. But we want to also support the system, so we aim to support the avoidance of readmission, bringing people out of hospital through our assisted discharge services, and then providing reablement support through our support at home services, which Helen's going to talk to you in detail about now through her case study.
Thanks, Alison. And one more, please, Tony. Thank you. So, we thought we'd give an example about what reablement looks like for a supported person. So we'd like to introduce Beth, who we have here. So the situation for Beth, she's an 87-year-old lady who's been admitted to hospital following a fall. She lives alone, and she's a widow without close family. So she might have family, but they are far away, not sort of on her doorstep. Currently, she doesn't have any existing support in place, so she doesn't have a package of care or isn't linked in with any other services. And she has been struggling to manage her day-to-day activities. It's getting increasingly difficult for her to cope with those day-to-day living activities. She's probably got at least 2 long-term health conditions, and her mobility is reducing. So she's finding it more challenging to get around and to be able to link in to manage those day-to-day activities. She's also, this example, she's hard of hearing, and that is also feeding in. So telephone calls are becoming challenging, interactions are becoming increasingly difficult for her to manage, and all this is feeding into low-level anxiety. It's become very difficult for her, and that obviously is increasing her levels of anxiety on a day-to-day basis. So if we look at the next slide, we will see how Beth might be referred into a reablement service, such as those delivered by the Red Cross. So we have support worker Pete, who attends the discharge meeting with hospital colleagues, and they said this multidisciplinary team would be made up of OTs, physios, social workers, others involved in the discharge planning for patients such as Beth. Everyone will feed into to Beth's plans based on their areas of specialism, and that review will inform that collective team that we feel Beth is able to return home without a package of care, but there are real concerns about her ability to manage independently, and she is at a high risk for readmission. As we know, that first 72 hours are a real high risk period for certain cohorts of patients for being readmitted to hospital, and we think that Beth might be in that group, particularly for falls risks and that adjustment back home again. So the MDT team decides that Beth will visit on the ward. Pete will visit Beth on the ward to have a little chat about what comes next. So on the next slide, we can see that Pete is on the ward and he is having a chat with Beth. He's there to say that the Red Cross can offer a bit of help to get back on her feet, and he'd like to hear from Beth about how she is feeling. So we have the information that's come through the MDT, but we really want to hear from Beth about what she feels about the future and what she hopes to achieve and what her potential fears and worries are. So Beth says to Pete that she has got a fear of falling again. It's happened once, and that's something that she's worried that is going to happen with that reduced mobility that we're already aware of. She has worries about coping at home. We know that she's been finding it increasingly difficult, but she really wants to stay in her own home. That is a priority for Beth. She is lonely and isolated, that increasing isolation due to the reduced mobility, difficulty to get around. We know she is now a widow, and that her family are quite far away, and the age she is means that her social network is likely to have shrunk. So she talks about being lonely and isolated. And she's got some real immediate concerns about how she's going to manage to get her shopping into the house while she's regaining her strength. So she's nervous about returning home, and there is also an overwhelming feeling of confusion. She's out of her usual environment, she's in the hospital with lots of people around her, and so she is feeling a little bit confused about what's coming next, with that anxiety still sort of constant in the background there as well. So on that basis, we move to the next slide. We can see that Beth and Pete work together to develop a support plan. So this is really talking about what Beth would like to achieve with some extra help, and how we're going to get there. So Beth identifies her top 3 goals through the What Matters to Me approach. And as you can see from the goals, this is what Beth has put forward in her own words about what she would like to achieve, her own outcomes, based on the conversation that she's had about her hopes and fears and concerns, and what the next stage looks like for her. So Beth's outcomes are: she would like to feel safe to go out and get my own shopping. She says that she would like to be less wobbly on my feet and know that if I do fall, someone will help me. And she wants to have more people my age to have a natter with. So from these 3 outcomes, Pete and Beth begin to form a plan about how they're going to achieve those individual outcomes. And they decide that the First Call team, which is the name of this particular service, will support Beth to get home when she's ready to leave, and with 6 weeks of home visits. So on the next slide, we can see, if we just flick to the next slide, thank you, we can see what that support looked like in practice. So we did provide transport home for Beth. Hopefully Pete, or perhaps it was one of his colleagues if he wasn't available that day, hopefully Pete, it would be that same face to transport Beth home, and then resettle her into her own home on the day of discharge. That would also include a home risk assessment when we get to that home site to identify any potential risks. In Beth's case, that fed on to a referral to the Avon Fire and Rescue Service, because there's some additional work that could be done to make her home safer in terms of fire risk. The resettlement also would have included a great deal of emotional support to reduce the anxiety and improve the confidence for Beth to get home. Also some practical support, so the ever important cup of tea and a bite to eat when we first get home from a long stay in hospital potentially. Checking that there is some food in the fridge available for those first few days at home, making sure that there are clean sheets on the bed, for example, possibly supporting Beth to phone some relatives or neighbours to let them know that she is home, and in her own setting once again. We then have a welfare phone call the following day to Beth, just to check how she's getting on and see how that first sort of 24 hours is going, and if any other immediate needs have been identified that Beth needs support for. That, as we've mentioned, that first 72 hours is key for the readmission risk. As we move into the 6 weeks of support that Pete and Beth planned for her when she was in the hospital, we can see that she's had a referral for a pendant alarm. So that is feeding back into her outcome about if she does fall, she wants to make sure that she's not going to have a long lie on the floor and that help will be coming. There's also support to get used to the new trolley that's been provided by the OT, so a new piece of equipment to hopefully reduce the falls risk for Beth in her home. And that support will be a lot of encouragement and emotional support to get used to using something new, but also just to have somebody on hand giving some practical advice about ways to use that equipment in the home, For example, with things like trolley equipment, the flooring is key, moving of rugs, trip hazards, wires. So there'll be that real sort of practical advice and guidance for her to begin feeling confident to use that equipment and reduce the falls risk. We provided support to go to the shop while Beth regains her strength and confidence. So at the beginning of the support worker or the volunteer would quite likely have gone to the shop on Beth's behalf for the first week while she's really gaining her strength. But over the coming weeks, that would have increased to Beth going with her volunteer or support worker. And then as we get towards the end of the support, tailing that support down so that by the end of the support period, Beth had been to the shop by herself and felt confident to do it on her own going forwards. We provided information about local groups and activities so that Beth felt that she could, in her words, have somebody her own age to have a natter with. And from the information provided, Beth identified that she was really keen to go to the local knit and natter group. She was a little bit nervous about making the phone calls, so we supported her to do that. With that hearing impairment, that can be challenging. So we helped to support the referral process into that group. And the volunteer went along with her to the first meeting so that she could really feel confident in how to get there, where she was going, and make some introductions to people for that first one so she felt confident going forwards. So on the next slide.
We'll just hang on 1 second.
Yeah,
there,
sure.
Yeah, it's really interesting. You're firing now lots of thoughts, ideas, questions. Some of them you're replying to each other, and all this is great. And it's just showing the very complexity of whether this is enablement as opposed to reablement, as one person said, about how we're playing to people's strengths, making connections. As we were just saying here as well, Helen, weren't we, that it's more than simply providing a service. What you're saying there about linking people with local groups and activities.
Yeah.
So you're using what's happening in the community to stimulate a better life, not thinking that we, the professionals, have got all the answers for people.
Absolutely right.
Yeah, so lots of kind of nods here. So keep all this coming. I think that really particularly key one about the language that's used, enablement, reablement, and all the models you're beginning to talk about. There's great conversation starting now.
I think it shows the diversity of the support that's provided actually, and why it's so key to have the conversations with the person about what their full picture looks like. It's not just that you've had a fall and you want to reduce your fall risk. Actually, that might be one element of what somebody is keen to work on, but there could be other things which are far more important to them and actually are going to have a bigger impact long term. So it really is about the quality of those conversations and the benefit of having somebody embedded in the hospital who can go and have those quality conversations and give the person the time and space to be able to come forward with what really is going to make a big difference to their lives.
Yeah, and that's the real focus, isn't it? And one of the questions earlier on, I'm remembering as well, I think it was from you, Emma, talking about outcome measurement. You know, how do we get into the impact of reablement as well? Okay, so keep it all coming. There's a great debate.
Great, lovely.
Did you want us to answer some of the questions?
Yeah. Alison, you want to come in?
So there was one a little bit earlier about what's the difference between assisted discharge and reablement longer term support. So assisted discharge is the support that we provide when we support people out of hospital, and that can provide, so that's support with discharge and then very short term support at home, either 24 or 72 hours. But what we tend to do then is link into the reablement support, which provides the longer term support, which is between 6 and 12 weeks. And actually this particular example that Helen's speaking about has that entire pathway, doesn't it, Helen?
It does.
So it works on supporting people out of hospital, getting them home and resettled, and then the support at home reablement package of care. There was a question, I think, as well about how do we, and Helen just referenced then about supporting people and connecting people into longer term support. So what we try and do is, as part of the goal setting, is look at how we can support and enable people to access other types of support in communities, and that's part of the offer that we. So we don't just call it signposting. We can signpost, but we refer to it as supported referral. So it's actually supporting people to access other sources of support that they need around them in terms of maintaining their independence.
Just to respond to a point that Paula made in the chat as well around 6 weeks of provision of entitlement, if you like, to a reablement service, and then after that people needing to either move on to a package of care or be independent. Something which a number of our services do is to work in partnership with NHS reablement services or social care reablement services, depending on how it's funded in that area, to actually act as a step down. So someone might receive statutory provision from a reablement service for the first 6 weeks, but then use a voluntary sector provision to do a step down, so it's not from you're getting weekly visits to nothing at all, and actually that can help just to make sure that that person's independence is maintained and there isn't a crisis point. So that's certainly something that's worth exploring.
Okay, yes, and we noticed that at 1:20 that 225 of you were connected into this conversation, and it's there's some really rich material, rich questions so appearing. Steve, can you remind me, are we all the questions and comments and so on? What did you say that we're making those available?
Yeah, we can. We can put them into a document and send them out with the slides and the recording. You know, in a couple of days' time.
Yeah, okay, and I think that's going to be important just because there's so much material there. Okay, right. So
just to say, we can respond outside of the webinar as well if
okay.
you want to email.
So there's Red Cross Alison's offer there to respond outside as well. Okay, so I'll put the next slide
please,
on there.
thank you. So we are now at the end of Beth's support period with the Red Cross, and we are coming to review what we have supported her with. So that support plan that we have mentioned a few times is regularly reviewed throughout the support so that it can be amended as required. Goals and outcomes will change and evolve. The ways of achieving them might change depending on how somebody is getting on. Throughout the support period, the exit from the support is always the focus. So right from the outset, we're saying, right, we're going to say we'll do 6 weeks or 8 weeks and see how we go, but we need to be planning towards that exit point and making sure that Beth has everything she needs to be as independent as possible at that point, or have other things linked in if she's not going to manage full independence. But that exit is always the key focus. Increasing independence is key. We've mentioned that around things like the shopping support, that we're aiming for that independence to be achieved and building towards that. And emotional support is crucial throughout the entire support period. So much of being able to live independently is the confidence to do so and feeling that you can manage, and so that emotional support is key. And at the end of the support period, the review of those outcomes will be completed with Beth. So what did matter to her, and do we feel we've achieved everything that she was hoping to? And if not for any reason, what have we done about that to make sure that she's linked in with more appropriate services if that need has been identified as something that she's not going to be able to manage independently beyond this point? Okay, so on the next slide, I think we're probably answering questions as we go. So let's continue on to the next bit, please, Tony. Great. So just to give a little summary of the service that we were talking about with the example of Beth. This is from the first call service, which the Red Cross delivers in Bristol. And this slide really gives just an indication of the scope of some of these services as a voluntary sector provider of reablement. So this is a service that is commissioned by the Clinical Commissioning Group. It operates across the Sustainability and Transformation Partnership footprint in that area, and that includes 3 acute hospitals and 3 local authorities. So it's a really large-scale service working with a number of partners there. It supports vulnerable adults to regain independence and confidence, as we've seen. And in this particular model, it is tiered support. So we are really offering support according to what somebody's needs are, up to a maximum of 12 weeks of home visits and telephone support for those who need it. There's a lot of flexibility in there to tailor it according to individual need, bearing in mind that we always want to offer the right amount of support to promote independence without creating a dependency on that volunteer or support worker. So it would be the minimum that somebody needs in order to get where they want to be with those what matters to me outcomes. And this model includes a rapid response supported resettlement element, as we saw in Beth's case, to get her home on the day and resettled. And that service does support for discharges and also to avoid admissions. So if somebody out in the community is at risk of admission, we have a team there to go out and to try and do some crisis work on the day to prevent that person ending up in hospital in the first place. So on the next slide, this just has the service outcomes for that particular first call model. There's a lot of overlap to our other services here, but these are specific to that service. So we can see that the service outcomes are the prevention of unnecessary admissions to hospital. As we've mentioned, that might be actually going out into the community to support people so they don't get to the point of being in hospital in the first place. Also working from the emergency department to prevent the admission for somebody who might have social needs but not necessarily a medical need. Speedier discharge from hospital, getting people home faster because there's appropriate support in place. The increased confidence and well-being that we've seen is key for maintaining independence long term. Decreased social isolation, so linking in, as we saw with Beth, into the knit and natter groups or whatever is right for that individual person to make sure that they are connected with their communities. And all that leads to the increased independence long term to prevent pressure on the system. So that's either through admission to hospital or the need for long-term social care, preventing that for as long as possible. So on the next one, please, Tony. I'm going to hand over to Alison for the next few.
Thank you, Helen. Yeah, and this is just an example of some research that we've undertaken recently. It's a report called Home to the Unknown, which we launched on the 14th of February. The research looked at how people were supported when they left hospital. So it was a UK-wide piece of research, and it looked how people were supported with discharge when they leave hospital, and specifically around how they were feeling about leaving hospital. And we did quite a lot of research around the home environment that people were going back into. And whilst we saw some really good practice, we also made some recommendations. So the link is on there for people if they want to have a look at that research in the detail. But part of the research made some recommendations for what we refer to as a 5-part independence check. So practical, social, psychological, physical and financial. So practical independence, as I referenced just before, might be an assessment of whether someone's home environment is actually fit for them to return to, because quite often we find that people's home environments can be quite challenging, and also whether or not they might need adaptations, for example. Social independence, we talk about that in the context of potentially supporting people who are at risk or who may be experiencing social isolation and loneliness, and we aim to provide meaningful connections for people. So when Helen referenced before, once the reablement support is at an end, we don't step away without knowing that that person or individual has been supported to access other types of support around them, as well as support networks. So it's not necessarily just practical support, it might be joining a support network, for example. In terms of psychological independence, we want to understand how people are feeling about returning home from hospital, and that might be around things like managing stress that could be associated with illness or injury, or the stress that people feel when they've been in hospital and they have to return home after perhaps an extended period of time. Physical independence obviously speaks very much to the reablement points around managing everyday tasks, and it might also look at things like whether or not people require short-term aids and adaptations such as wheelchair loans, for example. And then the final point is around financial independence, so supporting people's ability to manage finances or cope with day-to-day financial burdens.
Okay, I'll just butt in again there for a sec now. There's so much coming through here. I mean, it's a very, very lively debate indeed. Quite a lot about the positioning of reablement and how it differs from care, perhaps with more emphasis on personal goals and strengths. But it's making me think, let's remember that all care should ultimately be independence focused at its heart. Independence, as one of you said a little earlier, is about having control over life of your life, and the package of care, of course, helps to maintain that control. So I think there's a lot here, sharing a lot of information about what reablement services are defined as and look like in different parts of the country, in different, and that's really interesting. I think we need to think as well about how reablement links with everything that we're actually trying to do. But I don't know whether the trade-off is there with enablement or indeed whether it matters as well. But anyway, I'm just looking at a great debate coming through there. And we will try to get the balance right between the material from here and responding to the sorts of issues and questions you're raising.
So here are just some examples of how we work with other voluntary and community sector partners. I think we've referenced quite a lot of this already. So obviously the support that we provide more broadly is person-centred, and we've talked quite a lot about the outcomes-focused approach that we work to. We want to obviously provide holistic support, so that speaks to the piece around supporting people out of hospital, as well as the short-term, more intensive support, and then referring people into communities, and through that support, ensuring that people are supported longer term. But again, that speaks to the piece around the prevention of admission to hospital. What we want to do is support and promote independence for people so that they don't go back into hospital. And we also promote the social model of disability and, as we said, that person-centeredness. I think we are seen as a trusted brand. We get that a lot from our partners as well as the people that we support. We work with a lot of older people who very much value the role of the British Red Cross. Okay, so we've got a poll now.
Right, it's poll time.
Someone like to read it out?
Okay, so this is the question. What do you see as the most valuable outcome of voluntary community social enterprise sector reablement services? And do you want me to read the answers?
I'll open the poll now.
Poll's opening.
Okay, so some interesting results coming in. Lots of people flying to get their poll results through. Certainly that top one, better individual outcomes for patients, really does seem to be the one that speaks to the people in the webinar the most there.
Yeah, so it would be useful, as a little bit was flagged earlier on about how you actually measure the impact and the outcomes for individuals of reablement approaches or reablement services. I'm still, I wouldn't say confused, but I still think it's a really interesting vein of discussion, really. But yeah, that focus on and it's still coming through very strongly. And the next two, facilitating integration and bridging the gap, maybe you're seeing more as a means to an end, because integration and bridging gaps is really ultimately all about achieving better individual outcomes for patients.
Yeah, certainly. There's an interesting point about how you measure those outcomes, because they're, with preventative services such as these, it's about reabling people after they've had an incident, but ultimately it is a preventative service which is preventing things happening further down the line, and it is challenging to measure what hasn't happened. That is a challenge for services like this.
Right.
But it's part of the reason why it is so crucial that we are working to an outcomes-based approach where people are saying what they want to achieve, and we're measuring the rate at which they are achieving them. And that is something that we can measure and report on, which is crucial for demonstrating the impact, really.
And we also know, some of the questions are coming up saying we work with an outcomes focus. We know that there are lots of very effective ways to measure outcomes, and specifically across both health and social care. And one of the outcomes of the recent CQC systems reviews talked about a consistent measure, consistent metric, if you like, of impact and outcomes. And that is a challenge for both health, social care, and the voluntary and community sector, and how we get to that. that's a very big question, but we do know that there are many and varied positive ways to measure outcomes for people. There was a question about whether the service is just predominantly is just for older people. No, it's not for older people, but we see predominantly older people in our services. But it's not just for older people.
Okay, somebody was asking what VCSE stands for. Is Voluntary and Community Social Enterprise?
That's right.
Yeah.
Yes, that's right.
Okay,
So called different terms: VCSE, voluntary sector, charity sector. They're all terms.
Voluntary and community sector.
Yeah.
I saw an interesting comment a little earlier from you, Josie, trying to develop an OT service without treading on the toes of reablement. That really made me quite worried, really. If we're all supposed to be focusing on, helping people develop or regain skills that enable them to live maximum independent lives. So I did make reference earlier to a council that we're working with at the moment, where the reablement is definitely moving away from us being a service and really being seen as the centralising sort of approach that all services need to be contributing to.
And I think that is that key message with effective reablement is the person at the centre of it. And actually, it's not about which service is doing what. It's about that person at the core and people working around that individual to make sure that the outcomes they want to achieve are the main focus, and that everyone's aware of what that person's wanting to achieve. That communication is key.
And there's a few questions about connecting us all together afterwards. So I think that would be a really helpful and useful way to move things forward. So yes, happy to do that.
Yeah.
Sure, Helen and I can work with. I think we've got people's contacts up there, but Helen's contacts on the PowerPoint slides. So if anyone wants to link in with us, then please feel free. And I think Helen and Colin are both tweeting out today, so can contact us through Twitter as well.
And once again, for anybody who's joined in the last 10-15 minutes, repeat that we will be sending out to everyone this presentation material, which, as you say, includes Helen's details anyway. Okay, so I mean, to what extent, the big picture here, again, there's lots of really interesting ways in which reablement services are being provided. Oh, and somebody pointed out the importance of advocacy a little earlier as well, which we mustn't forget. I mean, to what extent do you feel in your organisations there is a unifying thread that everybody, whatever services are called what, building on what you were saying, Helen, I think really, whatever services are called what, at the end of the day, is everybody gathered around trying to help people achieve independence? Or does the creation of a reablement service kind of take it away from other services and so on, like, well, if it's reablement, it's over to you and we don't need to think about it? I'm probably describing that in quite a crass way, but certainly somebody hinted that a little earlier.
I think one of the key links is around that it's not just what happens in the hospital setting and people actually working all together and not just sort of passing over to reablement and that's it, but it's also about that link between the hospital and the community, health and social care and community services, all working for that individual, again, on their outcomes, so working collaboratively.
Yeah. I noticed, Tolu, you're there asking what's the correct answer for the poll question. I think we would definitely say that most of you got it right.
Not right or wrong, is it?
Yeah, it's not supposed to be about right or wrong. But, so I think looking again at these questions, I'd certainly see facilitating integration and bridging the gap as means to an end. The end has to be individual outcomes for people. Okay, what else have we seen?
Can I just say, Tony, in terms of, I go around the country, so that's the UK, there, for Scotland, Northern Ireland, Wales and England. I think the issues are pretty similar. So although you talk about an integrated service and commissioned services up in Scotland and Northern Ireland, the professional boundaries and the boundaries between different sectors do tend to get in the way if it's not about better individual outcomes.
Right.
So I think that is a really essential bit about it. And I think one of the things that the voluntary and community sector can help with is bring that person into the room for people. So when an OT is focused on the issues that they need to get through to assess somebody, to have them ready for home, or a social worker is juggling where to get that care package and think about the eligibility criteria, we can come in and just help be a bit of the glue around that. So the sector as a whole can play that role, and we can all remind each other and hold each other true to that bit about why we're here. It's about the person, not about our service, our hospital, our package. It is really something that, when you look at the best examples, and I've seen Rotherham's up there, I've seen a couple of places mentioned up there where I've seen the work, and it can really work, Knots as well, where it can really work quite well when you have that holistic approach.
Right, yeah, I think that's a really strong point, Colin, about seeing the focus on impact and outcomes, about, in a sense, the glue that, if we all focus on that, then we can, there's a question by Jerry there about risk-averse mindset. Does that get in the way of promoting reablement approaches? Do people at the front line, are they nervous of encouraging people to do things that maybe cause them injury or upset in some way, albeit, and that they will then get blamed for anything unpleasant that happens? Does that get in the way of reablement approaches?
I'd say it does. But also I think it's more people are worried about the individual. Again, they're focusing on the individual. They're worried about if they make a decision that might be a bit too, they're thinking it might be a bit too quick for them, and they leave them where they are rather than make a quicker decision to get somebody back home, or to make sure they give somebody some support in their home or where they're going back to make sure that they're supported. And quite often, and I'll just say this to be provocative, it'll be a health professional who's the most conservative about that, because they're focused on the clinical element, and I think that bit can get in the way, whereas, getting somebody home, most of the evidence shows that once they're home with some support, then you can start wrapping around them and giving them the independence.
Well, I think that's saying the clinical judgment forms part of it. I think, as you were saying, Helen, a good reablement approach enables you to focus on the whole of the person, really, which includes his or her aspirations and fears and so on and so forth, really.
And I think a lot also will come from the individual themselves, how they, if they feel that this is the route they want to take, then we should be providing the support for them to do that, to get to where they want to be. And wrapping someone in cotton wool is not going to help them feel independent and confident. They need to be able to feel that they can stand on their own 2 feet with appropriate support if needed, but we need to support people to get to that point.
Right.
And there are lots of people here who offer support at different places in people's journeys, aren't they? So, an OT, for example, isn't going to offer the same support as we do, but it's about joining all of that together, as you say, Helen, around the person. And I noticed that Colin's provoked some interesting debate there as well.
Yeah.
Yeah.
And Shirley, you're now saying that you want to be more risk-taking. I don't know what role you actually, what your role is in your organisation. Would you feel, and would others feel, that if you are more risk-taking, ultimately, who's taking the risk anyway? But if there's more risk-taking, less risk-averse approach, would you feel supported by your organisation, having acted, bona fide, behaved responsibly, recorded what you needed to record, and so on? Would you feel that you're going to be supported? Because if you don't feel that, then it's much more difficult.
Yeah, and it goes back to that support planning, that example that we saw of Beth earlier. She wasn't just sent off to go get her shopping on her own in the community. We built up to that point with her, with us doing it to begin with, then going with her up to a point where she felt able to do that. So it's about really assessing what the risk is and planning for how it's going to be a tailored move towards what that person wants to achieve.
Right.
There's an interesting comment there about how services are commissioned from Kate, and I think that that again, that's a really important point. Like I said before, we're all parts of care and support around individuals, but it might be that elements of support are commissioned in different, some's from health, some from social care, some might be jointly commissioned. We've got CCG commissioning here, so it is about that integration, isn't it, as well, around the whole person. Ooh, just lost our slides.
Okay, something's happened here. We're not seeing on our screen. If you can hear us at all, we've sort of lost the side of the screen at the moment.
Oh, there we go. Back like magic.
Okay, we've got about 15 minutes to go maximum. One or two of you might be able to run out, get sandwiches and so
I
on.
think we've got the next slide waiting.
And we've got the next slide.
Yeah.
That was a prompt, wasn't it?
It was.
And here it isn't. It's nearly there. And in fact, it's me. Okay, so again, lifting this up to, can you go back one, Steve, to that? Steve? Oh, right. No, can you go that one where there's 5? Oh, okay. Okay, yeah. So the big picture then, again, lots of different schemes there, and hopefully some food for thought, including around risk, and Shirley, you're particularly interested in that, I think. What does good look like for Reablement, would you say, nationally? When do we know that we've got a good approach, I'd say, not simply service? And how do we get there? What do we need to do in our localities? And again, how do we measure the impact? So some key questions there, really. Are there any things that you think we ought to be focusing on next, perhaps at national level as well as at local levels? And I think it's fair to say we produce this as a summary slide about what we're all trying to do, our strategic context here, moving in the direction of personalised, independence-based, strengths-based, outcomes-focused and risk-aware, not risk-averse approaches. And that applies to Reablement, and it applies to everything, I think, that we're trying to do in adult social care now, these days, really, and was pushed hard in the Care Act. Okay, I think there's a string of slides here on Reablement that we're going to send out to you, but I'm not actually going to go through now. There's some various practice examples. Draw your attention to the quick guides that we produced with NICE. There's a reference there for you as well, and there's an interactive web resource with that. Next few slides from Tower Hamlets, Swindon, Coventry, and some examples on how Lancashire County Council are seeking to measure the outcomes of their Reablement approach. Okay. So that's the end of the presentation. Certainly we're ready to spend another 5-10 minutes.
There are a couple more there, Tony, actually, if you'd like to just
Apparently
click on to the next bit. Yeah, and once more again. Okay. So this is just really to highlight some of the benefits that have been measured. This focuses on the first call service that we've picked up on throughout the presentation today. This is a quote from a service user who used the service in 2018, which I think really demonstrates the benefit of an approach like this. He said, "I think it's excellent, the service. I've got enough confidence. My family didn't think I was well enough to come home, but I knew that I could manage with a little bit of extra help. The OT was good at making me think different. Getting a bit of help actually gains you some independence, not takes it away. I don't know who else would do it though, other than Red Cross." I think really demonstrates, again, the importance of those quality conversations to talk about going home and what people might need going home and getting that appropriate support in place there. On the next slide, Tony, we've then just got a very little snapshot of a survey that we did with people who were referring into that first call model last year, just about the risk that might be there to service users had we not been there for them. You see that 91% felt that there was a risk to people, that 55% actually thought it was a high risk to people's health and well-being. On the next one, we can actually see some broader evaluation. The service was externally evaluated by Sheffield Hallam University. This is a quote from that research. So I won't read out the parts in brackets, but it said, without the first call service, stakeholders anticipated failed discharges, having to take risks, so it's interesting that topic of risk coming up again here, increased waiting times, and I think what's really crucial, this final part, and compromised emotional resilience in terms of patients not being able to settle back in to being home. So a comment that's come up a few times in the chat is around that mental health support, the emotional support, really giving people that confidence is crucial for everything else that we're trying to achieve. The next little snapshot is just a little snippet from a survey around patients in the hospital if they've not been able to refer in, what referrers felt would have been the next step. So this is really about the impact of the system itself, and you can see that the overwhelming response from referrals was that people would have had either an admission if they were in the ED or a delayed discharge. And for those of you who work in the hospital settings, you can understand and appreciate the impact on patient flow that that is linked to. If we move to the next slide, we just have here some of our key learning around what we feel are the key factors for effective voluntary sector reablement services. So something we've talked about a lot, an outcomes-based approach. It is key that these services are focusing on what that person is hoping to achieve and that we are working towards that, reviewing and adapting as needed. Flexibility of provision is also key. Things change and evolve and people need the service to flex in order to meet their changing needs. It is really key that the voluntary sector reablement service is an equal partner within the multidisciplinary teams, that those conversations that Pete, in the example we saw earlier, is having with Beth is going to be really crucial for informing other partners as part of that MTD meeting, to make sure that the appropriate support is in place for Beth holistically. That links to having hospital presence. One of the questions that I spotted earlier was someone asking about the staffing model for the rapid response element of the service, and that links to this, having people based in the hospital on a daily basis so that you are thoroughly embedded with the other support available is really important. For anyone who would like more detail on models, do just give me a shout. Very happy to provide them and have conversations about that. And also with that hospital presence, those strong community partnerships. These voluntary sector reablement services, whether it's the Red Cross or other providers, they are key for linking what's happening in the hospital, happening in social care, and happening in the community. And so you need to have all those links firmly in place in order for that to be really effective. So on to the final bit. I think we're just on to any final questions, and we've got about 10 minutes or just slightly under.
Okay, we're going to give you a chance to get to your 2 o'clock meetings and so on, really. So I'm going to ask Alison and Colin to make any sort of closing remarks, and then I'll bring this to an end. And it's great to see there's still 209 of you there, just showing how important a topic this is, and what great links you've made with each other as well. Alison.
Oh, that's fantastic, and thank you. And thank you for your participation. I think it's been a very interesting and lively debate, and I think we're all very clear that we're focused on outcomes for people, which is great. I think the partnership element has come through very, very strongly, and how we're all very keen to work together. I guess the question is, how do we do that? And that's the question that always comes up, I think. But we have seen some really good examples of practice just being shared through the chat there, and within and between ourselves. And I think it highlights the importance of these types of communities of practice, bringing people together and sharing our ideas and ways of working in terms of service improvement. We have a range of evaluations which we've undertaken, which we're happy to share. They're publicly available on our website, as well as the Home to the Unknown. And I think it's really demonstrated the strength of external partnership working today. I think we've made some great connections here, and hopefully we'll continue to build on those. So thank you.
Great, thanks, Alison. Colin, do you want to say something?
I think I've just got, I suppose, a call to action. Is that I think all of us, and it's brilliant. Thank you very much for having us, and the number of people shows how interesting this topic is about working with people for their reablement, is that we need to look again at how reablement becomes, whether we use the same word or whatever, the way of working to make the NHS plan realistically meet its targets. I think without reablement, we can talk until the cows go home about people and their outcomes. This is the key to making sure people are independent. And I think all of us have a responsibility to see how we can work better together to create better reablement services for people.
Great. Well, I think that's a really good call for action, Colin, and a great way of finishing. I hope this has been a good experience for you. Certainly we've enjoyed it here. I've had to face a few stern and hostile glances now and again when I've been looking up the slide process, but I've done my best, Helen. It's clearly a very important topic indeed. As I said, we will send out the presentation material and the flow of the conversation as well. And hopefully you'll be able to be in touch with each other, because you've been asking lots of questions of each other. So thank you very much indeed. Have a really worthwhile afternoon, and it's goodbye from Tony and myself. Yeah. I'm from Helen.
Thank you.
Thank you very much.
I'm from Colin.
Bye bye.